Thank you very much, Dr. Suresh, Dr. Vidushi, Amar, and Harshu. It's indeed a pleasure to be here, and as the topic of the session or the IC is PECO or cataract surgery in tough and challenging situations. I've been working on the femtosecond, and I wish to, because when we went on to the femtosecond laser technology, we were slightly apprehensive. The technology evolved over time, and now we are pushing the limit of the femtosecond cataract. Technology, as you can see, is evolving, and every 3 to 4 months there is an upgrade in the Lensex femto laser that we are having. And we are looking at how we can push the limit as to what exactly are the type of cases that we can do. The first case which some of you would have seen maybe is a phacoporphic glaucoma case, and yesterday morning there was a session on tough situations as to how you manage an intumescent cataract. Now, when you are looking at an intumescent cataract, the intrandicular pressure is very high, and you get the typical Argentinian flag signs. You have to use high molecular weight, viscous substance, you have to make small incisions, you have to try to aspirate and things like that, so that everyone comes up with something or the other to look at it. Now, this was a cardiologist who came from a city near to Delhi, had a one-eye crystal lens done by me, and had come to me with an attack of phacoporphic glaucoma. The pressure was 60, and we controlled the pressures, and I took him up for a femtosecond procedure. Since the cataract is very wide, the machine people told me not to do a fragmentation, but to use this for a capsulotomy and for making an LRI and the corneal incision. So you can see this particular case. We are centering, those of you who have seen a femto procedure, you need to center the capsulotomy where you want. This is the OCT that has come. Look at this OCT. Can you see this angle closure glaucoma? Narrow angle. You saw the swollen lens, it was very, very swollen. And this is the iris, this is the LRI that we are going to make. So we are just making these 2 points come together on the peripheral cornea. We are happy with this particular setting. Look at this swollen lens, and now we are pressing the machine on the gap. Just watch here. Look at that. Mini explosion. There's a huge amount of cortex that came out. But this is the LRI, primary incision, secondary incision. But what is of key importance to you is that we are doing it under closed chamber conditions. So if you do it under closed chamber conditions, you don't have a problem of runoff of the capsulotomy. You can see here, this is the capsulotomy. Despite that fluid having come and a small area of uncut capsulotomy, you are able to remove this capsule like a piece of cake. You can see how easy it was. I didn't do the chop with the phaco, but since it's a softer cataract, we are able to remove it pretty well. So today, if one has to work on a phacomorphic glaucoma or an intumescent cataract or a wide swollen cataract, this is a crystal lens that is being implanted. The procedure of choice should be a closed chamber capsulotomy with a femto laser assisted procedure. This is the end of the procedure. The patient post-operatively is doing pretty well. Now let's look at again pushing the limit. This is a case of trauma. The patient had a traumatic capsule. You can see this is where it is. When you do a capsulotomy, there is no way that you can cut these fibrotic. So you have to use often a vanas, and when you use a vanas, the capsulotomy becomes irregular. The video recording for the outside laser procedure is not there, but the laser has been done. You can see these air bubbles, and we have shifted the patient onto the OT. Now let's see, this is the side port that we have opened. We have pushed air. Can you see that fibrosis? Could you see that stain? That's and there is where there is a huge amount of fibrosis. You will see at the end of the procedure, but you can see that the capsulotomy is reasonable and fully done in this area. There is this part which is unattached, but the laser has been able to cut, as I will show you, and we will get a perfect round capsulotomy. You can see we need to use a capsulorhexis forceps. Try there is still an attachment at that particular point. We would do this, there is a stretch, so I'll just hold it from the other side and bring out the capsulotomy. So you can see that we are able to work on the capsulotomy and there the capsulotomy gets completed. So you can see this fibrotic capsule. We are able to do a good capsulotomy. This is the pre-chopped nucleus. I'll just run through it because this is just phacoemulsification in a white cataract. Okay, and now you can see, can you see this area? Despite the cortex have been removed, you can see this is the area where there was a lot of fibrosis, this entire area, and it's a round circular capsulotomy that we have. So you have traumatic capsules, you can work with the femtolaser, you have phacoemorphin, you can work if you have subluxations and vitreous coming, then also you can work with this particular laser. So this is, I would say, challenging the limit of the femto. Now this is a question asked to me, does it cut hard cataracts? Well, this is a grade 5 cataracts. You can see we have done a capsulotomy. You can see these incisions pretty well. This is where we have done the 6 quadrants that we have made. So you can see, look at the capsulotomy. Capsulotomy is really not a problem. It's the hard cataract that we are trying to focus on in this particular case. You can see the color of the cataract. It's dark brown to black. And we are going ahead, removing the capsulotomy, which we are able to do pretty well. That's the capsule which has come out. There you see that's a round capsulotomy. Now look at the ease with which we will be able to remove this. Now this is the first, the chop is not very clearly seen, but just watch this. As I hold this nucleus, you will see air gushing through. That means that the separation had happened in the lower part, and this is the pneumodissection that was there. Look at this cataract, it's reasonably very hard, as you can see, and the ease with which we have been able to crack this. Again, look at it, look at this, 90% depth. You can see that it had already been cracked, and we are able to emulsify this cataract with very little power that has been used. Post-operatively, you can see this is the patient, first post-op day, patient had clear cornea and a 6/9 unaided vision. Now let's look at another situation which earlier we were told not to attempt a femtolaser in post-vitrectomy eyes because the eyes tend to be bigger because they are myopes, and as also there isn't adequate support because the vitrectomy had been done. But we are doing this particular case, which is a post-vitrectomized eye with silicone oil. So we do this procedure with the femto and oil removal at the same. This is the capsulotomy which comes, as you can see, this is the OCT image of the interior capsule, the total. Look at this. This again is a reasonably hard cataract, and you can see the 4 quadrants that we are doing. This bar indicates the, as we are doing the chopping of the 4 quadrants, and there we keep coming up on the bar, and then we'll have the primary incision. As you can see here, this is the primary incision that is coming, and then you will have the secondary incision that is going to come here. So this, let's shift now to the OR. You can see that the dark brown color has come. That's because of the pneumodissection. The capsulotomy coming out is fine. We have been able to remove the cataract pretty well. Now what we do is that we do a primary posterior capsulorhexis in this particular case. You do a primary posterior capsulorhexis, you get the oil to come out. You don't need to go from a posterior aspect to remove this oil. All you have to do is, there is visco, because this oil came out, I put in some more viscoelastic so that I can complete the primary posterior capsulorhexis. Once you have completed the primary posterior capsulorhexis, you just need to depress the posterior lip and put the irrigation behind the silicone oil, and the silicone oil comes out. So you have a beautiful anterior capsulorhexis, you have a primary posterior capsulorhexis. The light is on, you can't see it very well, but and you can put in intraocular lens in the bag. Can you make out this is the primary posterior capsulorhexis? There have been some reports of people going back after removing the cataract and using the lens X to do a primary posterior capsulorhexis at that point. So, but in this particular case, we did a manual primary posterior capsulorhexis. Small pupils, I would say the only contraindication which is there for lens X is where you have to use actually iris retractor. The iris is actually bound down, because for the laser to work, you have to have a clear area. So if it's actually bound down, you can't do it. and the other is corneal opacities, dense corneal opacities. If you have corneal opacities, the laser would not be able to go through. Now this is a small pupil. Earlier we had a problem, but you can, even if the pupil comes down to you after docking, or if the pupil is small, you could reduce the size of the capsulorhexis. The lowest I have done is about 4.2. And you can see here, I just show you that maneuver of reducing. Here, can you see this? We centering the area, the quadrant, the capsulorhexis, and look at this. I'll just nudge this. Can you see this dot which has changed the color? We have just nudged it, and you can see that I have made the capsulorhexis slightly smaller so that we have a clear area from here. And look at this capsulorhexis. I am sparing the pupil, and I am able to do a capsulorhexis. So even if the pupil sometimes used to come down on us when we kind of docked, you can now play with the capsulotomy size and you can reduce it, and you can see that we have an adequate good capsulotomy that we have been able to get in this patient of femto. We'll just go ahead and do the phacoemulsification, which is really not a problem. So friends, over this last year and a few months, I've been able to push the barrier or push the limit in harder, difficult, challenging cases. You could do it even in children, but that needs to be done under general anesthesia. I have still not ventured, but KP Reddy has talked about doing it in children. I've talked about primary posterior capsulorhexis being possible after as a secondary, but the wound needs to be tight. So that is the only thing, because when you are doing all this procedure, it's a closed globe and you have not meddled with the globe. So subluxated cataracts, again, when you try to do a capsulotomy by cutting or pulling, that is where it gets a shearing and you don't get the capsulotomy here because it's a laser and it's cutting through. So even in subluxated cataracts, the capsulotomy would be coming out pretty well. So I would say that the next decade, maybe after 5 to 7 years, this could, like phacoemulsification became the gold standard. The prices of the machine will definitely come down, which they are over the last 1 year. We have seen them drop. As competition hots up, the machines will become cheaper, the per procedure cost will become less. That is the basic impediment today for a mass scale utilization. But if you ask me a question today, would I like to do a femto for every patient who can afford? My answer is yes. I would want to do it because it has elevated the level of cataract surgery to a new level. I still remember when we went into phaco, I used to make presentations called phaco just a fashion question mark. So I think today we are making a presentation femto cataract just a fashion, but I think I don't have any question marks in my mind today, and I think it is going to take us to the journey of perfection. Thank you very much for that.